Good morning. This is Babak, Larian. Hope you're doing well. Today is June 4th, and I'm doing another live session. This time we're going to talk about parotids and parotid tumors, as well as the need for a needle biopsy. And why is it a good idea to go ahead and do the needle biopsy? When I was training, my professors, who were phenomenal doctors, phenomenal surgeons, used to say, great majority of times, that whenever there's a tumor in the parotid gland, it should be removed. So what's the point of biopsying, right? Especially because needle biopsy results are not 100% accurate, right? And you should operate, and at the time of the surgery, make active decisions. And I oftentimes had issues with that because, we'll go through it and I'll explain why I have issue with that. And it is true that they're not 100% accurate, but the accuracy rate is, fairly high. It's 70% of the time. And so overall, but I'll describe more. So let me begin. I'm gonna go ahead and turn this around. All right, so just going through the basic statistics. Parotid gland tumors make up about anywhere between 1 to 3% of all tumors that happen in the face, neck area, throat, whatever, if you cover all that whole area. In the US, it's roughly about 4 per 100,000. Fortunately, in the parotid gland, 80% of the tumors are benign. Only 20% are cancerous, as opposed to the other glands, which the chance of being a cancer is much more. And most of the salivary gland tumors happen in the parotid gland, so at least you could say the statistics are favorable in that regards. The World Health Organization, has categorized parotid tumors or salivary gland tumors into benign, epithelial, and epithelial means lining, tissue, the tissue that makes the lining of any organ. So this lining of skin, the mucous membranes in your throat, the linings inside the lungs, linings inside the salivary glands, the areas where they produce saliva. That lining tissue is epithelium, right? So benign epithelial tumors, and there's more than a few, right? Pleomorphic being the most common, right? So 80% of the tumors are, in general, benign, and of that 80%, 72% are pleomorphic adenoma. So pleomorphic adenoma, right here, is the most common type of tumor that happens in the salivary glands as a whole, and in the parotid gland, even more so. And there's a whole bunch of other ones, right? Interestingly enough, pleomorphic adenoma is the only one of these benign tumors that has the potential of becoming a cancer in the future, right? So leaving pleomorphic adenoma inside a person is not ultimately wise because it has a potential for transforming and becoming an aggressive cancer, while the other ones don't have that potential, right? And that's an important distinguishing factor for doing a needle biopsy, because if you are, let's say, a 50-year-old man, woman, 50-year-old person, right? And you have a tumor the size of an almond, right? And it's actually not visible, right? So when you look at the person, the tumor is not pushing out on the side or here. When you touch it, you can feel it. You've had this tumor for a few years. It's not growing. It's staying the same size. So it's no sign of progression of this tumor. If you do a needle biopsy and you get basal cell adenoma, a benign tumor that's not going to grow, then the need for treating it is less urgent, or potentially not even necessary. You can continue to monitor it. But if you get a pleomorphic adenoma that has the potential of becoming cancerous, and you still have a long life ahead of you, 30, 40, 50 years ahead of you, then that chance is a real chance then that should be addressed, and that's important, okay? But moving on, there's also a whole list of cancers that can happen, again, organized by the World Health Organization. Cancers, which the numbers are even more types of cancers that can occur, mucoepidermoid being the most common, followed by this odd creature of a tumor called adenoid cystic carcinoma. And so the potential for cancers is fair. And then you have mesenchymal tumor. A mesenchyme are not lining tissue, but the tissue that's behind the lining. So the fat and tissue that's under your skin. Those are called mesenchymal tumors, right? And so these are the benign types: a lipoma, benign tumor of the fat, schwannoma, benign tumor of the covering of nerves, and then you can have sarcomas, so mesenchymal cancers, right? So the number of types of things that can occur in the parotid gland, in the salivary glands, is a lot. And so that needs to be taken into consideration. Why is it that there's so many things that can develop, so many different cancers and benign tumors? It's because there are many different types of cells inside the parotid gland, right? So the lining cells are acinous cells. They produce saliva. These are the ductal system, different types of ductal systems, right? And ductal cells. You can see 3 categories of them. And then to support those ductal systems, you have sebaceous cell clusters, lymph nodes, epidermoid cells, goblet cells, and muscle cells, myoepithelial cells. So you have many different cell types, and these many different cell types, based on the work that was done for engineering salivary glands. So the scientists that were trying to figure out how to engineer and make new salivary tissue discovered some of the nuances here, that there are stem cells. These stem cells give rise to what's called progenitor cells, which are infant cells that can become many things. So the stem cells can become anything. These are next step closer to being salivary tissue, but these can become any kind of salivary tissue. And as you can see, these stem cells that make the yellow progenitor cells, and then the progenitor cells can make ductal cells, or they can make acinous cells or muscle cells. So they have so much potential, and they can turn into anything, and therefore if a tumor develops in these areas, it has the potential of becoming any type of tumor. It can go in any direction, right? And that's important because you can get tumors developing from any aspect of the salivary gland. This is the duct and the salivary secreting units, the acinus, and so on, and these are the muscles, and so on and so forth. So different types of tumors can develop in different areas, and because of different progenitor and stem cells. Fortunately, as of late, we have this Milan needle biopsy system for doing a needle biopsy. So when you do a needle biopsy, you put a needle through a hollow needle, like when you get an injection, vaccine, and so on, that kind of a needle through the parotid gland while aspirating, meaning while sucking on the plunger of the syringe that's attached to the needle, to suck up any kind of cells that you get as you're going through the tumor. So you don't do the suction action as you're going through the gland, but once you hit the tumor, and you can do this under ultrasound guidance, so you know when you're entering the tumor, and once you enter the tumor, you draw on the plunger, sucking in whatever cells you can get. You are at the mercy of the tumor, in the sense that the tumor, the generosity of the tumor is what dictates the architecture of the tumor, the looseness within which this tissue lives with each other. It allows you to get sampling. So some tumors are more architecturally more set up for giving samples. Some tumors have a lot of blood vessels in them. And so as you put the needle in, you're gonna get more blood than anything else, and that may obscure what you're seeing. So the character of the tumor also is important in what you can end up with, right? But you're putting the hollow bore needle inside the tumor, hoping to get enough cells in there that when you spread under the microscope, on a slide to look under the microscope, you can see enough what's going on and be able to tell, right? So in generality, The needle biopsy has a 70% accuracy rate in all comers. But with the Milan system, you get a little bit more information about your needle biopsy. Let me transfer you around. So let's start with first non-cancerous. So when you do a needle biopsy and the pathologist says there looks like there's inflammatory tissue, there's no tumor cells that I see, right? Then there's a 10% chance that there is still a cancer there hiding within that tissue. If they say that we see atypical cells, we see some salivary cells, but they look atypical, we can't tell if that's meaningful, or is it just atypical looking because there's inflammation. We just don't have enough cells to be able to tell. Under that circumstance, there's a 20% chance of there being a cancer. When they say it's clearly benign, and to say this is a basal cell adenoma, or this is clearly a pleomorphic adenoma, then there's a less than 5% chance of there being a cancer. When they say it's a tumor, but we can't say for certain if it's benign or cancerous, then there's a 35% chance that it's cancerous. When they say it's cancerous, when they say it's suspicious for a cancer, there's a 60% chance. And when they say it's cancerous, more than 90% of the time they're accurate, right? So there's a degree of accuracy that goes on. And then when you do a needle biopsy and you just can't get enough cells to where they say it's non-diagnostic, then there's a 25% chance that there's a cancer there, okay? So some of the cancers are not very generous in the way they do things, in the way they give you that. So why is all of that important? The facial nerve. So the facial nerve courses through the bones of your skull to come out and go into the face and do all that it does in moving your face, giving you expression, giving you your ability to communicate effectively. And so that facial nerve being in that area really affects how you choose to address and how you choose to make a decision to treat a parotid tumor. And I can't emphasize how important the facial nerve is. I think most people think of the facial nerve as a cosmetic thing, or that if you have paralysis, you're going to look a certain way and so on. Yes, on a cosmetic level, you will. The more important thing about the facial nerve is that it is what allows you to communicate, right? It is what gives us the laugh lines. It is what gives us the frown lines. It's what gives us the expression, the way your eye looks, the way your smile is, and all those things. And the harmony between the two sides, the disparity between the two sides that you actively use by raising one brow or the other, all of those things have information that you're relaying as you speak. And as you all well know, a lot of the way someone communicates happens through the way they move their hands, move their face, and so on, just as equally important as the words that come out of their mouth. So it is extremely important in your ability to relate to the people around you, and not have them be distracted away from what you have to say and what you have to express, right? And so the facial nerve is much more important than just the cosmetics of how you look. It's vital in the way you communicate. Being that it is that important, when you have a tumor, the tumor can have any kind of relationship with that nerve. So this is the facial nerve. The tumor can be superficial to it, deep to it. The nerve can be going over it, or the tumor can be wrapped around it. And oftentimes, when you do a scan, an MRI and a CT scan, because you can't see the nerve, you can't tell what that relationship is. You can do a very good guess that it's superficial or deep to it. You can't really say this tumor is wrapped around based on what you see. But there are certain tumors that like the nerve. There is a tumor called adenoid cystic carcinoma that has a predilection for involving the nerve. And once it attaches to the nerve, it uses it as a highway to move to other areas. That's just the genetics of that tumor that allows it to use the nerve as a highway. You know, other tumors don't use it as a highway, but they eat into it, and they can eat through the nerve and cause paralysis. And benign tumors generally don't do any of those things. And so it's important to know that. And then when you have recurrent tumors, either benign or cancerous, you can have multiple nodules in there. And so you have to figure out what you're dealing with. And when you know what you're dealing with, then you can decide what to do. So this is a slide of cancers. But before we talk about the cancers, again, going back to the benign tumors, if for example, me today, I'm on my late 40s, if I have a benign tumor, it's again a centimeter. It's not obvious, or if it is, it's a minor little bump that doesn't personally bother me, doesn't affect how I feel about myself, right? And it doesn't draw attention in a way that upsets me, right? And I do a needle biopsy and it comes back as a Warthin's tumor, a basal cell adenoma. And let's say I've had it for 4 years, it's grown very little, and it continues, and I continue to monitor it. I'm able to do an ultrasound very easily and measure the size and what it's doing to make sure it's not growing inwards. And I can see this. I do the ultrasound, let's say once a year, and I see that it's not growing, or growing very minimally, 1 to 2% change here, not so much. Then I can sit back and say, hey, this is never going to become a cancer. The needle biopsy has been very certain. The pathology report is clear as to what it is. It's not behaving like a cancer. It's not acting like a cancer. And I know on the needle biopsy what I have, and I have easy access to ways of measuring and making sure it's not growing inwards. And by having all those things available to me, I know that I can monitor this tumor very well. I choose not to have surgery and not to put my facial nerve at risk. That's an important decision. That's a really vitally important decision. Without a needle biopsy, it would be hard for you to make that decision, because there are cancers in the parotid gland that are slow growing, right? So low-grade mucoepidermoid carcinoma, actinic cell carcinoma. These are slow-growing cancers that may not grow rapidly and show you that that it is behaving like a cancer. So you can't just use the behavior alone, right? But if you have a needle biopsy that says this is clearly a Warthin's tumor, not something that is potentially cancerous or suspicious for a tumor, you have a clear answer, right? Which makes the chance of it being a cancer based on the Milan staging system less than 5%. And it's not growing, and it's not behaving as if, okay, this is going to grow and maybe potentially really engage the nerve or push on the nerve or cause any issues with the nerve, that the risk surgery will have more risk if I wait 2, 3, 5 years from now. If those things are not existing, then I have the option of sitting back, monitoring it, and not doing surgery, not putting my facial nerve at risk. So when you put your facial nerve at risk by doing surgery, you have to make sure that you are making a smart and active decision. And without the information coming from a needle biopsy, that decision is not as informed as it could be. And in terms of cancer, you're dealing with a whole different ball of wax, right? If you have low-grade cancers that are slow stage, or high-grade cancers in the lower stages, the treatment is different. You know, with low-grade mucoepidermoid carcinoma or actinic cell carcinoma, yes, you should have surgery, but should try to avoid removing the nerve or cutting the nerve at all costs. You don't need to remove the lymph nodes, and more than likely you don't need to do radiation. That may change if the tumor is wrapped around the nerve and you want to preserve the nerve, and you may feel like you have some microscopic disease on the nerve. But if you don't have that, you don't have any obligation to do radiation treatment, right? And most of the times, these low-grade tumors don't wrap around the nerve, so that's an advantage, right? With the high-grade tumors, they can involve the nerve, and that's the plus minus. If they do involve the nerve, you may have to cut that nerve branch, and if they don't involve the nerve, then you can separate them, right? You may or may not, depending on the stage size and type of tumor, need to remove lymph nodes in the neck, and you probably will need radiation treatment to prevent recurrence. In larger stage tumors, more of the same, but more leaning towards nerve resection and neck dissection and so on. And in very advanced cases, a lot of these things can happen. And so, with this one, resection of the nerve is something you mention to the patient, but with these others, not only do you have to mention it to the patient, you have to get the patient's consent. You have to ask this person, okay, friend, if I go into the operating room and by chance I find that your tumor is wrapping around the nerve branch, what would you like me to do? What is your priority in your existence, okay? And that's really important because it's your body. You get to decide what you want to prioritize. I can tell you my recommendations. I can tell you what each treatment path will involve, and you get to make the decision, but you can't make that decision without having enough information. And so that's why I think doing a needle biopsy is important, because it allows you to make informed decision to go to the operating room or not, right? To address the facial nerve in a way that you choose to address it, right? Do I sacrifice it? Do I do everything I can for the sake of you having survival and cure? Or do you prioritize your facial function because of your job, your choice of life, or whatever that is, whatever is important to you, which is the only thing that really matters. And say, I won't sacrifice the nerve. You take your chances and you want to do radiation, and that's accepting to you the decreased potential for cure, but the possibility of cure still with radiation is an acceptable risk that you're willing to take. And that is only a decision you can make. I or your surgeon are here only to give you information so you can make that active, informed decision that's appropriate for you, okay? I hope this helps, and hope you guys have a wonderful day. I look forward to talking again next month. Bye-bye now.